Tēnā koutou, tēnā koutou, tēnā koutou katoa. Nau mai haere mai ki te hui a Consumer Research and General Practice. I ngā mana, i ngā reo, i ngā kaimahi whānui, whakatau mai nei. Ko Bridget Allan tōku ingoa. Ko te kai whakahaere o te Awakairangi Health Network. Welcome everyone to this webinar on Consumer Research and General Practice, organised by the Healthcare Home Collaborative and Health Navigator. My name is Bridget Allan. I'm the Chief Exec of Awakairangi Health Network, and I'm the co-design champion in the Collaborative Governance Group. We're going to start tonight by asking Merle to take us through a karakia. Thank you, Merle.
Tēnā koe, Bridget. Anei, he karakia tīmatatanga. E te atua, he honore, he karoria, ki te atua, he maungārongo ki te whenua, he whakaaro pai ki ngā tangata katoa. Hangai e te atua, he ngā kauhau, kei roto i tēnā o mātou. Whakatongia tō wairua tapu, hei awhina, hei tohu ia mātou katoa, ake tonu ake, āmene. Kia ora, Bridget.
Kia ora, Merle. Thank you so much. So I'm delighted we're holding this webinar tonight, and I'd like to introduce our panel. You've just heard from Merle, who's the consumer representative for the Healthcare Home Collaborative. Merle identifies with Ngāi Te Rangi, Katikati in the Western Bay of Plenty, and she's been employed as part of the wellness support team of East Tamaki Healthcare, Nirvana Healthcare, since 2013 as a patient advocate, cultural advisor, peer support specialist, Stanford self-management master trainer, facilitator and health coach. We've also got Gary Sutcliffe on tonight's webinar as well. He is another consumer representative on our Healthcare Home Collaborative and coordinator of the Health Consumer Advisory Service. Gary's background is primarily in mental health, starting when he accessed mental health services due to experiencing depression and anxiety associated with an impending business failure in the early 1990s. Gary retired from the workforce in April 2017 after 3.5 years employed as a peer support specialist, self-management facilitator and health coach with East Tamaki Healthcare. However, in his retirement, he continues to be contracted as a consumer auditor of mental health and addiction services and does voluntary work in the community. Another of our speakers tonight is Dr. Janine Bycroft, whom many of you will know as the Executive Director of the Health Navigator Charitable Trust. She was also the founder of Health Navigator New Zealand. She's a GP, a Flinders trainer and clinical lead at ProCare Health for the Healthcare Home Initiative and a new Well Plan project with the Ministry of Social Development. Her areas of interest include collaborative care, care planning, self-management support, quality improvement, chronic care, e-health, health literacy and integrated care. We've also got Dr. Fiona Imlach, Senior Research Fellow at the Health Services Research Centre. She got her medical degree from Auckland University, worked as a medical registrar and a GP, and then ended up training in public health medicine. She now works as a researcher after getting a PhD in epidemiology from Otago University. And her previous research has included social determinants of health, child poverty and alcohol, and she's currently working in an HRC-funded program on primary healthcare services in New Zealand. So you see we have amazing resources with us here tonight. And thank you all very much for all the time and preparation you've put in. So tonight we're going to start with the Victoria University of Wellington research into consumers' experiences of primary health care during COVID-19 lockdown. Fiona. And then Janine will share with us some themes from recent focus groups that assessed patient access to general practice post-COVID lockdown. Merle and Gary will then share some of their consumer whānau experiences. Towards the end of the session, we will have the Q&A function where you can put in your questions as we go through the webinar tonight. Put your questions in there and either we will answer them during the presentations and in sort of 20 minutes or so towards the end of our evening together. So with no further ado, I'll hand over to Fiona to take us through her research work on consumer experiences of primary health care during the COVID-19 lockdown.
Right, I'll just share my slides. Okay, so thanks for the opportunity to talk tonight about some early results from the research that we did during lockdown about patient experiences. Just give you a bit of background about why we did this research. We were, as Bridget said, we were doing some work on primary healthcare, and I was trying to look at patient experiences in healthcare homes in the Wellington region actually, and we were pretty much ready to go to interview patients when COVID-19 came and we went into lockdown. So that project had to stop because we couldn't recruit patients, so we couldn't do face-to-face interviews like we planned. But we thought that there was an opportunity to do something actually related to the pandemic and the lockdown experience. So we changed our focus to that. And the reason for that was twofold. One is, as you know, primary care was pretty much forced to adopt telehealth or virtual methods during the lockdown period. So everyone in lockdown, which I mean level 3 and 4, had to have a virtual consult before they could be seen in person. And this was a massive change for services and for patients as well. And during the lockdown period, for several reasons, the usual patient experience surveys were not taking place. So the Health and Quality Safety Commission have an ongoing patient experience survey. Just by bad timing, that was in abeyance during lockdown, so that wasn't going to happen. And of course, the New Zealand Health Survey is a face-to-face survey, which also collects a bit of data on patient experiences, but that couldn't happen during lockdown because it couldn't be done face-to-face. So both of these surveys did actually develop alternatives, so that New Zealand Health Survey developed a telephone alternative, but it didn't actually collect very much detail about telehealth or access to primary care during lockdown. And the Health and Quality Safety Commission did a survey retrospectively looking at experiences in level 3, but we were really keen to capture the experiences of patients in this really disruptive time at the time. So we wanted to get a survey or some research during lockdown happening. And just a bit of context, which you'll all know, before COVID and before lockdown, most consultations with primary care are in person. There'd been some telephone triage and some telephone consults, particularly in healthcare home, which has that as part of its model. And there were some progress being made in terms of the patient portal, which can improve access and telehealth services. So in 2019, around 2/3 of practices were offering a portal, but there wasn't a very high registration of patients for the portal, and very few were using video conferencing. So what we did was develop an online survey. We wanted to capture adults who had needed to use primary healthcare during the lockdown. Because of this sort of unusual situation we were in, we couldn't use our usual sampling frame. So we recruited through our own social media and email list, and very much helped by Health Navigator. Thank you, Janine. And we had over 1,000 responses for the survey, which was just what we needed. And from the survey, we recruited participants for in-depth interviews, and we completed 38 interviews to explore a bit more detail about how people found accessing primary healthcare during the lockdown. So you'll see later on, I've got some data from the survey results, the quantitative results, and I've also included some results from both the interviews and the open-ended questions in the survey. So I've presented those as quotes, which you'll see. Just to give it a bit of context, the research and pandemic timeline. So we were interested in level 3 and 4. We got the survey in the field near the end of level 4 and during the second level 3. And most of our interviews were actually completed by the end of level 3, but a few carried on into level 2, looking backwards. Because of our sampling frame, we have to acknowledge our sample was a little biased. It's not representative of the usual population that attends primary care. So we had more women than men. We had a reasonable age mix. We didn't get as many Pacific people as we'd like, but we knew that it would be difficult to recruit Pacific people through an online survey. And we just have to accept that as a limitation of the survey. We also recruited more than average from Capital and Coast and Southern regions, because that's where our university affiliations are. So that's where a lot of our contacts are and our networks that we use to recruit. So just keep in mind that is a little non-representative survey, and that could influence some of the results. But just in general, the the thing we found was most telehealth was by phone, and that won't be a surprise to any of you, because even though people were using Zoom a lot in their social connections during lockdown, it wasn't very common to be used in primary care for lots of reasons. So only 5% of people had a video consult, but 61% of the survey respondents had a telephone consult, so that was pretty common. The other interesting things, just in terms of general contact with primary healthcare, most of it was through phone, but 30% made contact through a portal or a website, which would actually be a bit more than we would expect from the pre-COVID uptake of portals. So which suggests that either practices or both practices were providing these more often, and more patients were registering them and finding them useful. So a couple of quotes around that. Oh, and just, we did have a look at healthcare home practices, and we found that patients from healthcare home practices were more likely to have had a telephone consult before than patients that didn't have healthcare home practice, which is not surprising, and it shows that healthcare home practices are implementing that part of the model. So in terms of the online access through portals, these are just two quotes from giving two examples of the kind of extremes that people had. So the first one is somebody who was used to access their practice through the online portal, and then the portal was closed at the start of the pandemic, and so everything was filtered through the telephone. And that was actually, this person found it aggravating, and other people said that actually it was really hard to get through on the phone, and sometimes they just gave up. But on the other side, there were some people who did use things like Manage My Health and found it a really good experience and helped access, and they wanted it to continue. So back to telehealth. So telehealth in this context is telephone and video consults. The satisfaction was really high, and actually really high just when you think about the fact that everybody was forced to do this, and still it was, patients were very satisfied overall with the telephone and video consult. There wasn't any significant difference between healthcare home practices and non-healthcare home practices, but there was some indication for some aspects that telehealth might not be as good as in person. And so this slide shows that. So we asked 4 questions around the quality of the consult. Things like, did the clinicians spend enough time with you? Did they listen to you, explain things to you? And again, overall, extremely high levels of satisfaction with this. So over 90% overall for telephone, video, and in person. But you can see the red part of the bar is the proportion of people who thought that, for example, the telephone consult particularly, that spending enough time with you wasn't as good as in person, or listening to you wasn't quite as good as in person. So still overall people were satisfied, but there were some things that might not have been as good as if they could come and see someone face to face. And there was no significant differences between healthcare home practices on these indices either. One of the explanations for how telehealth can work well is if you have an existing and a trusted relationship with a provider in continuity of care, then that can help telehealth work well. And that came out in our data. So you can see that a couple of quotes there about how people found it was no less sense of empathy. They had a good relationship, they had a trusted relationship, and the telehealth worked well. But there were a few people, and that's the last quote here, that the in-person experience, empathy is not replaceable by phone consults. But for some people, probably no matter how well you do the telehealth, they still want to be seen in person and have that relationship in person. Another issue that can arise is the concern about not being physically examined. So there were definitely things that people raised that they thought that they should be seen, they needed to be seen. And there's about a third of patients were moderately or extremely concerned about not being physically examined. And again, this is not surprising. And it's actually found quite reassuring that 2/3 of people weren't really concerned at all. So that was a lot of people who didn't think that being examined was a barrier to telehealth. And again, the context of this is the fact that everybody had to have this as sort of a screening before they could be seen. So there were a lot of people who didn't find that a problem. The other thing that came out is people were quite good at identifying when they thought they should be seen and for what sort of conditions and issues that they wanted to be seen. There's some examples here. One patient said that it would be hard to demonstrate pain even in a video, that there's some kind of signs that you see when you walk into a room where the doctor can pick up that is difficult to pick up, definitely in telephone, but even by video. And there's some issues that would be easier to manage by telehealth. So things that are known, things that are routine, things that the patients are familiar with and their doctor are familiar with, that can be managed quite well by telehealth. but some things which are a bit new or scary, they wanted to be seen in person. And of course, there's some tests that are difficult to do by a patient. You know, a patient can't check their own prostate, for example. But actually, this other example here about the blood pressure, there's people can do things like that at home, but they need to be supported and set up to do that. One issue that came up, but not actually as much as some of the other things, and I have to say overall, all the comments that we got were way more positive than negative, but cost came up in a few cases. So overall, most telehealth consults were charged the same as a regular consult, but one concern that people did have is that there's quite a significant proportion who didn't know how much they were charged, and from the interviews and from the survey responses, that seemed to be because either they weren't told how much it was going to cost, they didn't get an invoice in a very timely manner, they were waiting for days to be invoiced for the consultation, or they just didn't know how much they were charged for this. There were some people who were charged less. And there was no significant differences in costs between healthcare home practices and non-healthcare home. So some comments people made about the cost, generally people thought were pretty good at judging what was fair and for the time and money that was put in. So people thought that if they had a telehealth consult that was very short and didn't go into much depth into their issues, that they didn't really want to pay full price for that. But some others were quite prepared and quite happy to be charged full price for consults when they got that value and they felt like they had the time and they got a similar sort of service that they would have got in person. So quite varied responses there. But obviously there needs to be some work and negotiation and communication about what's an appropriate level of remuneration. One other concern that came up a little bit was around privacy and safety. And one of that, particularly if you're talking about sensitive issues, so that first quote was from a woman who was talking to her psychologist online. And most of the time that worked fine, but occasionally she would think, oh, is somebody listening to me? And in the context of the home where family could be listening outside the door, she wasn't sure, that did constrain her. And some things people are not sure about how secure things are. If you email or you text some of your personal information to your doctor, is that going to be safe and private? And there were some comments around the physical safety, and that came up, I guess, in the context of COVID. A lot of people were afraid of being exposed to this infection or bringing the infection home. And so that was the thing about safety. The telehealth was a safe option. They didn't have to go out and expose themselves. And so the telehealth was better from that perspective. There were some technology barriers for some people, or just that people were concerned that others would miss out because they weren't able to afford broadband or the technology, or they didn't know how to use this sort of technology. And some people might need a bit more support for this to work. And there was one respondent here who just couldn't handle the telephone because he was partly deaf. It didn't work for him at all. Although the video consults, he said he could manage that. This kind of summarizes it really. For some people, they found telehealth really great. They would actually prefer it. So there was one example here about how she really felt that the telehealth gave her a better service, and she wouldn't have been able to get this type of service and help for her issues if she'd had to go in to the doctor. She wouldn't have even bothered. But there was other people that just didn't find it easy to do telehealth, especially if you do have some anxiety issues sometimes that was exacerbated by not having that in-person contact. We asked people what they'd like in the future, and we asked them about what they're aware of before the pandemic happened. And you can see particularly video consults, people have very low awareness, that's the blue bar. But some awareness of some of the other things that we might want to offer in the future, but very, very high level of preferences for telehealth options in the future. So even the video, where you would think that people, if they're not very familiar with it or not very aware of it, that maybe they'll be a bit reserved about wanting that kind of thing in the future, but still nearly 70% of people were willing to try this, even if it wasn't a familiar thing for them. And one of the reasons, and this is backed up by literature before COVID, before lockdown and pandemics, about why telehealth is a good thing for patients, is really the convenience. So it can work very well for people who value convenience, who need access to primary care in a way that's quick, and they don't have to spend a lot of time traveling or waiting, especially if you're in rural areas and you have to take an hour or more to get to see your doctor. This can be a really good alternative. So, and there's another comment that came out a few times, and particularly for this this man, the second quote there, he talked about the fact that he might actually go and see his doctor more, and it would encourage him to go seek help because it was more convenient, and he felt like he could do that in a way that suited him more than if he actually had to go in person to see the doctor. I guess ultimately really is that people want choice and they want to have the service matched to what they need at the time. That need might change. Definitely for some things people want to be seen in person, but for other things they were happy for a telehealth consult. And so this person really summed it up in terms of, well, find out what people want, find out what's appropriate for people, find out what they're capable of in terms of do they have the technology to support a video or do they need some extra help, and match the service to what they need. There were some issues around the research that was particular to the context of COVID and the lockdown. And one I've mentioned briefly is this fear of infection was really high, and people were probably even more willing to embrace telehealth options because of the fear. They didn't want to go out. They didn't want to go and sit in a waiting room and have someone cough on them. They didn't actually want to expose the health workers to infection either. So they were quite protective, both of the healthcare workers and of themselves and their own families that they might expose to an infection. So that in that way, telehealth in this context was a really good alternative for them. A lot of people talked about how they found it easier to get to their primary care during lockdown. It was less busy. They could get an appointment quicker. One person said that she usually waits for 6 weeks, but she could get an appointment the next day, and that was just revolutionary. So that's probably not quite the same now, but it's something that shows that there can be efficiencies which will benefit patients with these methods. And people did note that in some cases, especially at the beginning, when people were transitioning to e-prescription or different ways of working, that poorly functioning systems were quite off-putting and were a barrier to access. And if they got the sense from staff that staff were panicked or stressed or not coping, that put them off from seeking help as well. Just in summary then, what can we learn from this experience that we've been to? I think the satisfaction data and the results that we got from our qualitative interviews were that most people like the telehealth options, but not everybody. It really depends on the person, the health issue and circumstance. And for some people, it's not as good as an in-person visit, but for some people, it actually might even be better. And that convenience and the time efficiency, not having to travel, is a real bonus for a lot of people, but it's not appropriate for everybody. We found that patients were pretty good at judging whether they needed or wanted to be seen and when telehealth options were appropriate. And they're very willing to try. That was the almost surprising thing, is the willingness of people to try new technologies, adopt them, make them work. So if they had a video and it didn't work, they'd switch to telephone, they'd send in photos, they'd do everything that they could to actually support getting good access to care. Most people also have a fair idea of what's value for money in terms of time and the quality of the consult and what they get out of the consult. And really summing it up, a successful telehealth, like any consult actually, requires a mutual trust between the patient and the provider. And interestingly, we did sort of expect that patients that had existing relationships with their providers and continuity of care, that would be easier. And it does seem to be the case, but that's not, it's not an essential thing. So there were certainly lots of stories about patients who established empathy over the phone or by video with providers that they hadn't met before, and it could still work really well. So that's it for me. Just want to acknowledge my research team. Great thanks to all my interview participants and the survey respondents that gave us this information, and the Health Research Council for funding this. And I'll just stop my...
That's great. And so please, people, if you have questions or comments on what Fiona has shared, please put them into the Q&A system and we'll pick them up at the end. I mean, Fiona, I just want to acknowledge that it's great to have this kind of really in-depth support from patients actually wanting options and being so positive about the telehealth options and seeing that as being a very important thing for the future. So thank you very much for that, for sharing that research with us, and we'll come back to you. Janine, can we move to you now? If you can start to share your slides and take us through your presentation.
Kia ora everyone. It's great to have the opportunity just to share some of the work that's been happening here. So this was some focus groups that were done by recruiting people through the Health Navigator website and work with Healthcare Home Collaborative. And it was really interesting. We got contacted by quite a lot of groups across the country of people who were really interested in research around the consumer perspective. And so, yeah, it was really great to have the opportunity to try and gather that. So I'm just going to run through these, some similar themes to what Fiona's already covered. So I'll just go through those quickly. As we know, the impact of COVID was enormous. We're all going to be aware of that. There were a big reduction in numbers of consumers going into general practices, but there was huge psychological impact for everyone. Obviously, it all happened very fast, and I'm continuing to see a lot of people with ongoing anxiety or depression that's potentially been triggered by COVID, or just sort of the life stresses that have all become just exacerbated through this experience. It was obviously, as Fiona has mentioned, a huge change for general practice. For those of us who are working in general practice, I've just zoomed home from the practice tonight, we changed over the weekend from seeing everyone basically in person to being expected to have 80% telehealth by the Monday morning. So there was many meetings over that weekend as we all tried to gather our wits together and understand quite how we were going to change so rapidly. And then of course by the Wednesday we were going into lockdown that night, and then by Thursday morning it was virtually all telehealth. This did have a big impact on the viability of general practice, and some consumers were aware of that. Some will have had no idea of the impact, but obviously we were also seeing lots of patients and consumers who it had a huge impact on their jobs and their livelihoods. We've got really quite limited understanding of the consumer experience of what it was like accessing care. So that's why it's really exciting to see the work that Fiona and team have done to reach so many people. And there'll be some other research projects coming through, I'm sure, over the next few months from that time. So the question that the team, particularly led by the Healthcare Home team, looked at for this was, how has COVID-19 pandemic affected their patients' behaviour and their experience in accessing care from general practices? So what they did is there were 6 focus groups, and these discussions were using Zoom. They had 1 to 3 consumers, and the discussions, as you can see there, lasted about 30 to 45 minutes. And then there were some email interviews as well. So key findings, again, pretty similar. So most participants had been in contact with their practice over the time. Common things, so repeat prescriptions, routine checkups, injuries. So that was obviously one thing people still needed to come in for. Talking with other groups, bike injuries, electric scooters, and these were some of the more common things that appeared in those first week or so, as people got on their bikes that they hadn't ridden for a long time. But it was also really exciting to see lots of people getting out and walking and getting more active over that time. How people could contact practices did vary. So phone, secure messaging through portals, and then in person were common things. Some practices did actually end up closing their websites, as Fiona mentioned, in that initial phase, as they were getting used to quite how the best way was to screen people, because before that a lot of us had our portals set up where people could book appointments directly, and obviously we couldn't have people coming directly in straight in for in-person consults without them going through a really careful screening process and seeing if there's anything that could be done using telehealth first. So again, findings are very similar to what Fiona has found in terms of mostly it was positive experiences, and similar things. People found that the less waiting time, the convenience was wonderful. As you'll see here, that quote for this person, it was much better. She found it was, yeah, it was really positive, and consumers had a reasonable understanding of the pressures that the healthcare team were under. Sadly, there were some negative experiences, and this is just one quote that captures that. This person had broken their ankle, and that's actually before COVID, on the 7th of March, the lockdown, and had a long wait. So it was 5 weeks before they actually got that follow-up visit, which is obviously much, much longer than we would normally expect for that to occur. In general, a lot of those referrals actually would be by specialists and often done by fracture clinics through ED or after our clinics. So it would be interesting to just dig into that one a little bit further to really understand quite what happened and why there was such a long delay. Yeah, again, similar, some safety concerns and not always being communicated fully to people before they were seen. And that was perceived differently depending on the person's circumstances. So for children, if they were needing to be seen in person or over the phone, that was obviously a very different experience for them. And one person there mentions patients with autism, obviously very different to their normal way of being seen, which often needs to allow a little bit more time and communication to make sure that that goes more smoothly for people. Obviously, people did notice the changes. They were having, as you went anywhere, you're often having to obviously keep distance. People come into the waiting room and the chairs, there were only a few chairs in the waiting room, or people were standing or kept 2 meters apart. Hand sanitizer and the contact tracing, of course, was an important part of that. There's mention here about increase of certain services such as home visits. This would be more particularly by community services, and there weren't many practices doing home visits that I'm aware of. So some of the suggestions that came through from the participants that were part of the focus groups were the value of potentially extending business hours for general practices. And this is something that general practice really does need to consider, and is a key part of healthcare home, is that we do need to be extending our hours. Even though maybe we don't really want to be doing those longer hours, it is actually really important to improve access. So if we're serious about that, then we need to really consider how we can set ourselves up as teams to make that after our care more accessible for our consumers and families. Is there a way that we can partner with organisations, with other practices, particularly in rural areas, so that we can provide those longer hours? What are the precautions that need to continue, and yeah, what are we going to do about continuing to offer phone and video consults? Certainly one of the things that I observed across a lot of practices is that, and as shown by Fiona's results, is that it was 95% was telephone, and that the offering of video consults was much, much lower. But there were a few things that contributed to that. Webcams were very hard to come by, and I know there were lots of PHOs and organisations trying to access webcams for their practices, but they were in very short supply across the country because, of course, everyone went digital and went remotely working from home, and so they were in very hot demand. They can still be actually quite difficult to come by, so that's one thing that practices are needing to prepare for and put in place. There was also a lot of work around what are the services that can be used that are considered to be secure and safe. So platforms such as DoxyMe and Zoom were the two that were the most commonly used across this time. And then how can we increase support with referral services just to make sure that people were getting the care that they needed over that time. So we'd love to hear more from you. We do want to keep getting feedback around your experiences for consumers over this time, and also suggestions and comments about what we can do to improve this going forward, and to continue to review and refine the model with the Healthcare Home. And the recording will be available on the Healthcare Home website. So thanks very much for your time and attention, and look forward to answering some questions that you might have later. Thank you.
Thank you, Janine. And I think that's great again to hear the consumer voice coming through and being so positive about what was able to be done during the lockdown period. I wonder when we come to the Q&A, I might have a couple of questions myself about, for practitioners and practices, that what could have been done to have assisted them to make an even smoother, transition into it, given the speed with which. So if I could pop that one into your heads to start thinking about now, and we'll come back to that perhaps later on. And because I think as a Healthcare Home Collaborative, we're very keen to know what more we and our partners could be doing in that space. So I'd like to come now to via Merle and to Gary, who are going to tell us a little bit about, from a whānau perspective, a consumer perspective, some of the stories of what happened in that time. We in the governance group have been privileged to hear some stories over that time, so I know this is going to be really valuable for everybody on the webinar. So I'll hand over to you two now.
You'll have to unmute yourself there, Merle. After you, Merle.
Kia ora mai tātou katoa. Thank you, Fiona, Janine and Bridget. As one of the consumers for the Healthcare Homes Collaborative, yes, we do have a few stories to share about the COVID-19 lockdown. Like, I'd like to start first. I actually went to my GP to get my flu shot. When I went to the front door, I actually went to the surgery because somebody else had told me they had been. I never thought to email, and because I always knew there was a wait. I hadn't been out of the house for a while, but I go down to the surgery and there is somebody sitting at the front door. So she's blocking the door, but she asks me what I want. I said, oh, I've come to get my flu shot. And she said, oh, you go around the back. So I walked right around the back of the surgery, and somebody came to the door, which halfway up it has a glass partition that opens. They didn't open the whole door, they just opened the glass partition. And I said, oh, I think I'm coming in to get my flu shot. And she said, pull your sleeve up and put your arm through the hole in the door. I did do that. I started rolling up my sleeve, but because I am outside, I can see either side of where I am, the rubbish bins line that wall. And I didn't know if I wanted them to carry on and give me the shot. And I thought, well, I'm not sure how I felt. I was already there, I should have it, or shall I say something about this? And yet inside myself, I thought the shot would help against the COVID. I don't know. A lot of different questions were happening, but I came away from there not really sure how safe that was. Safe for me because I could see what was either side of me. The people in the clinic were serving from the door, so they had no idea. If they never used that door to come in, they had no idea what was there. That was the first incident, and that was between level 3 and 2. The other incident was with a whānau member. She took her baby to the doctors. They went to the front door. The receptionist told them to go around to the back door. And when they got there, a piece of paper and a clipboard with a pen on it were pushed through the door, and they were just told to fill that in first. They were not offered a telehealth or a teleconference or a virtual conference. She had to go back 3 times. So that was just before we went into lockdown. And I still do not know why she wasn't offered a teleconference. baby did have a rash. I think what was sad for me to hear that was that although they were sending people around to the back door, they were not making them comfortable. My niece had a baby and she had the form to fill in. There were no tables or chairs. There was nothing for overhead. I think, and what I have been involved in with healthcare homes, I find it hard to hear that other practices treat their patients like that. Kia ora, I will actually pass it to Gary. Thank you, Gary.
Kia ora, Mel. No, thank you. Thank you. Yeah, a lot of experiences that really you shake your head a wee bit and sort of think that shouldn't happen, even in these circumstances. But look, my own experiences of during COVID were quite different. I too had flu jabs, and my wife and I both had flu jabs, and there was a sign outside the main door just inviting people to go. There was some seats on the side of the building. The nurse came out. All of her came out, not just her arm with a needle on it, and that was all fine. So she introduced herself. So it was a good contact with that. One thing I did do that I've talked to people about patient portals and didn't have one myself, and I wanted to make a contact with the doctor, but like some of Fiona's information that came out from the study is that I didn't really want to bother her by making an appointment. So I said, look, I want to register for a patient portal. So that was helpful. I was able to convey that through the portal, and I got a fairly good response and a fairly quick response to what I had to say. The only other experience was our granddaughter. She's at Otago University, and she had a problem with her teeth, and it was bothering her quite a lot, and she rang up and was told she couldn't make an appointment, but she did have a very successful consult with a dentist, and she was really happy with that. So it's kind of like, you know, I guess Merle and I have had quite opposite experiences, so that worked quite well. As you heard in the introduction from Bridget, my background is in mental health, and a couple of months before lockdown, before COVID really hit us, I had quite a bad experience, and I had to access mental health services. But what I got from that, something that was really positive from that, was the 1737 service. And I sort of thought to myself, had that happened during COVID, whilst that would have multiplied probably the stress, the triage process and the way that it was done, the warmness of it, really gave me some faith that had that happen, and possibly did happen to people during COVID, that hopefully they had a positive experience for that too. So that's probably about all from me, Bridget. Yeah.
Thank you both, because there is inevitably a range of experiences that happen, and I think we will, through our Q&A and discussions, perhaps we'll explore a little bit more about how some of the not so wonderful experiences might have been made better. Fiona, you've indicated that you might have a story to share which might also illuminate some of the pressures people were under, and yeah, so I'll leave it to you.
I was just, thanks Mel, I was just reflecting when you were telling your story about the environment and how you get that sense of how you're treated. It reminded me of a story that one of the interviewees told us, and it really stood out to me, and I've got it here. I'll read it out to you. She says, she's talking about getting a COVID test. She says, it's an unusual experience sitting in your car, what almost feels like an army type environment where you've got this makeshift tent, these sort of weird fences. You drive through this one-way thing, there's all these rows of cars and people are sitting there, and all you can hear is coughing. And you can hear, because of course they're fully PP'd up and they're having to yell at the other people in the car. So they're yelling at them. So you know what everyone's temperature is. I hadn't mentally prepared myself for what this experience would be like. So then they come to you, and the natural thing you do as a human is that you look at people when they're talking to you. Like if you're polite, that's what you kind of do. We're doing this now. So every time I went to look at them, they'd say, don't look at us. What? So they're wanting you to keep your head forward, your face forward, so you're not looking at them. So then you're sitting in your car, and instead of them passing you things, they just throw them into the car because they're not wanting to touch you, because they're not wanting to waste their PPE or whatever. I couldn't see their faces. I couldn't see who they were. So I had no idea, no relationship with them. And also for me, masks are hard. So that experience was quite activating for me. I can totally understand how and why it was and what would be going on. But I think there's an opportunity for learning around how some of these things can feel for people when you're actually going through them. I think that summarizes some of the, the feelings from the patient perspective. They could see that there was these safety things and they appreciated why it had to be in place, but sometimes it felt really alienating and quite like they didn't want to engage with it because it was really hard for them. This was a lady who had quite significant mental health issues. And she also made another great comment, which I've just pulled up. She's talking about how during COVID, there was all these messages about being kind and that it's okay just to do your best. And from her perspective, this was really almost bizarre because she was told when she was in a psychiatric unit that it was unfunctioning and a symptom of illness that you had to stay, when you wanted to stay in your pajamas. So we weren't allowed to stay in our pajamas when we were in the psychiatric unit, but now it's okay. It's okay not to do things. And so it's really unfair in this environment. It's acceptable to have this life experience where you want to spend time in your pajamas, but in other life experiences like the mental illnesses that she had, it's not acceptable to want to spend time in your pajamas. And I thought that was really a valuable insight, as we were accepting of people's anxiety or stresses during lockdown because it was something everybody was feeling and everybody could relate to. But we need to really take that empathy and translate it to people who have other difficulties in life. And sometimes these people get marginalized because they're not understood. But this almost gives us a platform in which we can understand people's distress and isolation. And maybe we'll become a more empathetic service because of it. That's me.
Great, thank you, Fiona. And I think that is very thought-provoking indeed. I'm aware for people also working in residential care and things, that same barrier that the PPE put up was actually quite scary for quite a lot of the residents and some of aged care as well. So, and therefore the ability of us as practitioners to engage well with people despite having these other barriers, I think is pretty crucial. We've got a couple of questions coming up. Thank you, Rebecca. It's great to hear these experiences from Janine's and Fiona's research with a balance on the positive and the themes are familiar. The consumer feedback from our area was more predominantly negative. What learnings have you got that might assist us to encourage patients and providers to utilise telehealth? And I wonder whether or not perhaps we might start perhaps, Fiona, with you, just in terms of any thoughts you've got in that space.
I'm assuming, Rebecca, that you're in a primary health organisation. I mean, that certainly people were clear that in some circumstances, in some contexts, that telehealth wasn't going to work for them and wasn't appropriate. So maybe it's what that woman said about asking people their preferences and trying to match services with what people want. So that's one thing, I think, is being more clear about what services you can provide, when it's appropriate to do telehealth, when it's not, and that has to be something that you work out with the consumer or the patient. And I suppose also the things that came up were around some people didn't have the setups to do video, and that's something practices need to work out their systems, but also patients need support about how they can get access to the technology when they don't have it. And also not blaming the patients for that. I've seen some research where they're basically saying, oh, the barrier is on the patient's side because they don't have broadband. Well, that's not the patient's fault. It's almost like you're saying that they've got to sort themselves out. No, that's a system problem. And so it needs a wider solution than just telling the patient to sort themselves out.
And that's a really good point, Fiona, which I think we'll come back to because we've got another question which has popped up in there. But just, are there any other things that our panellists would like to share in terms of the ways that we could encourage patients and providers to utilise telehealth more? Janine, any comments?
Yeah, so I think one of the things that some practices did well, but in a majority we could do better, is communicating to our populations what the options are and giving them links about how to use telehealth. So we've created a number of resources on the Health Navigator website with the National Telehealth Forum and Healthcare Home around explanatory fact sheets, how to access DoxyMe or how to access Zoom, what are the things to do to improve your sound or your video quality. So they're just some of the practical things that can make a big difference for whānau to have confidence to give video a go. For instance, we all just switched to the telephone predominantly because it's easy, we're familiar with it, there was no learning curve, but there is a learning curve with video, and so we need to actually support people with that. The other thing is that communication. Myself, I belong to attend a large practice. I think I got one text or two texts over the whole time of lockdown, which from a big practice, I sort of expected there might have been more contact to just let me know what the options were, that I could still get appointments. Obviously, I had inside information, but most people won't know. There did end up being a bit of publicity from the GP College, letting people know that general practice is still open, but obviously that took time for those messages to get out there. Other things that people can be doing is actually setting up a little bit of a focus groups with your own patients and whānau. Ask them what their experience was. Do some little surveys within your practice, and the more we engage with our own populations, the more relevant the services we develop will be. And there are groups called patient participatory groups where some practices start to have lunch once a quarter or whatever with a group of invite some patients to join them, and they just get such valuable and rich feedback by starting to develop those partnerships and relationships. So yeah.
Yep, so thank you, Janine. I think that's a great point, because one of the benefits I know our practices in the Hutt Valley have found is having those patient groups who give them advice. But Gary, I wonder whether or not you might have some comments about how practices could actually involve consumers in helping them shape their services, and any advice in that space.
Sure, just building on to what Janine has just said, to engage effectively with consumers or your patients is to initially make that contact and get their feedback on their experiences, and then invite them to be part of the development and improvement of services. And the key to that is to keep them involved, if they're willing to do so, to keep them involved right throughout the whole process. So it's almost like the what do you call it, the whiteboard sort of thing. We're starting off with a blank board, and okay, so ideally what would the service look like to you, and how would it best meet your needs? But keep them involved in that whole development of whatever it is you're trying to improve, right through to implementing it and evaluating it, and also letting them know what the results of that, keeping them informed so they don't sort of feel, I've just filled out another survey and I never hear anything, so why bother? But if the trust has been developed with that, then people are going to say, okay, yep, I want to be part of this because I feel my voice could be important and might make a difference.
Right. Thank you, Gary. And just to say that if people are wanting to know more about how to go about doing that, Merle and Gary both offer huge value to our whole collaborative, and so you can always get in touch and pick their brains more. So thanks, guys, in advance for that. Just on the question and answer, Tony has asked about for people with mental distress. There's quite a lot of people who, even if they have a cell phone, often don't have the money on their phone to be able to contact services over lockdown, and making therefore things pretty inaccessible for them. And are there some ways that we could be advocating through, to system improvement around making it easier for people? Janine, do you want to have a bit of a think about that one, how we could actually potentially do some work in that space?
Sorry, I just got sidetracked trying to read the next questions. Multitasking. Yeah, Yeah, sorry, just phrase that again, Bridget, sorry.
So just aware that, you know, digital inclusion is a very positive thing, but actually it doesn't, we haven't got everybody able to have either the devices or the data plans, the money, to actually be able to use the technology to have the telehealth experiences. And so Tony's been asking about, could we have free phone numbers for GP and things like that would actually make it possible. But I'm actually also wondering whether or not there's a job for the collaborative to actually be raising this up at the sort of central government level. And just, you know, panelists, any of you panelists might want to comment on that.
I know there are some plans around the whole sort of digital inclusion space, and that we really need to be doing that work now. I mean, there's always the risk we would go into lockdown again, so we need to be thinking and preparing for that. And of course, this was a classic example where those who need it the most are less likely to have the technology. The other option is for education and health to work together, because there was a huge amount of work looking at providing devices to families for children for schooling. And is there opportunity to also look at some of those families that would benefit from a device from a health perspective as well as education? So I'm sure that with all the sort of big data we have these days, there could be some matching done to sort of identify whānau that would really benefit from those devices. Iwi have also been doing quite a lot of work looking at their whānau to see where technology can make a difference, and providing actually support for how to use the device, because there's no point just giving someone a device and then expecting them to know how to use it. So some of the iwi are doing some really great work in that space to develop sort of coaches or digital assistants that can then also provide the training and support for whānau. One other thing that's just been released by the Ministry of Health is announcing the zero rated data. So what that means is 10 websites have been identified as useful websites across the country, and if someone's accessing from a mobile phone and doesn't have data, they'll be able to access those websites. So some of those have yet to come on board because there's often quite a lot of technical changes that need to be made, such as the Health Navigator website. There's a whole lot of work happening in the back end to make that doable, but that will become more accessible over the next few months as all those websites start to come online for that. So there are some good stuff happening, but there's lots of room to keep working on that. Thanks, Bridget.
Thank you so much. And I'm aware we're coming towards the end of our hour together. Gosh, it's gone so fast. Were there any final comments that any of you wanted to make that, you know, just to help round us off? Merle, was there anything you further were wanting to say? Might need to unmute.
Aroha mai. I think having heard what has been shared this evening, I'm truly grateful for the collaborative of healthcare homes. I am more aware that some of the experiences that we have mentioned, we are moving through that, and not only for all people that will access the service, but even in my own role, for many Māori Pacifica, I can see how the equity that we are working on to uplift, or the inequities that we're trying to work with in the literacy. I know that over COVID-19, there have been quite a few things misunderstood about how to use, when to use, where to go, and also for the fact that I've always felt I accept what comes before me. So I have never known that there may be another model of care out there operating differently to what my doctor is giving me. And over the COVID and through my time of being present with the group, I feel so blessed and enriched tonight, because the things that are shared more and more, those small whānau groups, and taking time out with them to increase the literacy, Māori literacy, people literacy, but because hearing how I can do more of that through tonight's webinar, I'm excited. Inside, my head feels like it's really moving because the things that you have given, and I've been working with some of those things, but I never heard it like this. So I am happy to let there be an explosion in our whānau about what we are doing and what's available, and also about feeling okay to go back and ask them, the GPs, for an explanation about why a telehealth wasn't offered or a video consult wasn't offered, because our whānau member came away thinking, oh, I just won't go back. Mum can take baby next time. So there was nothing in there, but from what I've heard tonight, I'm truly grateful for the panel. Thank you for sharing more that feels real to me, that I can actually allow our whānau to realise there are other ways that people are serving us as the consumers. So, kia koutou katoa ngā mihi mo tēnā kōrero atu pō. Thank you, Bridget. Kia
Thank you.
koutou, Scott, Amajit, Gary, Janine.
Thank you, Merle. That is just a lovely way, I think, to round off. Can I just thank all of our panellists for the expertise they have shared, but the heart that you have all brought to this work tonight, and the sharing. And just to encourage people, I'm going to see if I can make my own screen come up again. Just to remind you of these resources that are available to support you. As our team have said, this recording will be made available for people. And please do be in touch with the various healthcare collaborative, healthcare collaborative people you've seen tonight. There's a virtual consumer panel coming up if you would like to register for that. We'd be very happy to have your support in it. And so now to close, Merle, could you please close us with our last karakia? You need to unmute, Merle.
I will be great at the next webinar and I will remember this. Kia ora mai tata katoa, nei tētahi atu karakia whakamutunga. So we end tonight's session with the closing prayer. Anei, kia tau, kia tātou katoa, te atawhai o tō tātou ariki a ihu karaiti, me te aroha o te atua, me te whiwhinga tahitanga, ki te wairua tapu, ake tonu ake, āmene. Pōmari e koutou katoa, tēnā koe Bridget mō tō mahi kai arahi. Tēnā koutou katoa.
Kia ora, Mel, and kia ora all. Thank you so much. Good night.
Good night.